Hello everyone and welcome. Today we are going to tackle a very high-yield topic in pharmacology, the azole antifungals. Now this isn't just about memorizing a long list of drugs, okay? It's actually a story of how we learn to fight a very tricky enemy. And if you understand this evolution, it's key to using these drugs safely and effectively in your future practice. So, let's get right into it.
So, here's our game plan for today. We'll start with why fighting fungi is such a big problem in the first place. Then, we'll meet the pioneer of this drug class, see how his successors came and fixed his biggest flaws, and then we'll compare them all side by side. After that, we'll look at some of the newer specialists and finish with the absolute must-know points for your exams. Chalo, let's begin.
All right, so first things first, we're talking about antifungal drugs because fungal infections, or mycoses, they can be anything from a simple nuisance like dandruff to really life-threatening systemic infections, especially in our immunocompromised patients. The challenge has always been to kill the fungus without harming our patients.
And that brings us to this very fundamental question. Why are they so tricky to treat? Just think about it for a second. Unlike bacteria, fungi are eukaryotes, just like us. Their cells are much more similar to our own human cells. So that makes finding a drug that is selectively toxic to the fungus, but not to us, a huge pharmacological challenge. This is the stage upon which our whole story unfolds.
And every good story needs a hero, right? Or in this case, maybe a flawed hero. Let's talk about the pioneer, the first of his kind to really change the game, ketoconazole. You can think of him as the grandfather of all the oral azoles that came after him. Now, to really appreciate its importance, you have to understand what came before it. Before ketoconazole, our options for serious fungal infections that you could take by mouth, they were extremely limited. This drug was a total game changer, effective against everything from simple skin infections to deep systemic mycoses. But, and this is a big but, it came with some serious baggage. And that's why its use today is so very limited.
And here it is. This is its fatal flaw, the reason its systemic use is so rare now. The problem is, ketoconazole just wasn't selective enough. See, it works by blocking a fungal enzyme that's needed to build their cell membranes. But it also blocks a very similar human enzyme that's involved in making our steroid hormones. So what do you get? You get decreased androgen production, which can lead to gynecomastia, that's breast development in men, loss of libido, even low sperm count. This is a critical safety point, Beta. This is why we absolutely had to find something better.
And if the hormonal effects weren't bad enough, ketoconazole also created a massive traffic jam in the liver. It's a really potent inhibitor of our CYP450 enzymes, the ones responsible for metabolizing countless other drugs. So when ketoconazole blocks these enzymes, the levels of other drugs like warfarin or statins or your anti-diabetic sulfonylureas, their levels can rise to toxic levels. This makes it incredibly difficult and dangerous to use in any patient who's on multiple medications.
So the need was crystal clear. We needed a drug with the power of ketoconazole, but without all of its dangerous side effects. And that's when the next generation, the successors, arrived on the scene, the triazoles, led by fluconazole and itraconazole.
And this single slide, this comparison, it captures the leap forward just perfectly. Fluconazole directly solved the biggest problem of its predecessor. How did it do that? Well, it's all about higher selectivity. It was engineered to be much better at targeting the fungal cytochrome P450 enzyme, and it left our human enzymes for steroid synthesis alone. So, no more hormonal side effects. This was a massive win for patient safety.
But fluconazole had another superpower. It could go where other azoles just couldn't. You see, it has excellent penetration into the brain and the cerebral spinal fluid, the CSF. And this is what makes it our go-to azole, our preferred drug, for treating life-threatening fungal meningitis. This is a unique clinical application you must remember. It's a favorite Viva question.
Okay, now let's look at a sibling, itraconazole. This drug represents a different kind of improvement. It doesn't have fluconazole's amazing CNS penetration, no, but its advantage lies in sheer power and range. It has a broader spectrum of activity, and critically, it covers molds like aspergillus, which fluconazole does not. So this gave us a powerful new tool for a completely different set of dangerous infections.
Okay, so we've met the grandfather and his two very successful children. Now let's put them all side by side in a proper head-to-head comparison to really understand their individual personalities. This is very important for making good clinical choices.
This table, it sums up all the practical differences beautifully. Just look here. Absorption. Ketoconazole and itraconazole both need an acidic stomach to work.
That means you tell your patient no antacids. Fluconazole? It doesn't care about the pH at all. CSF penetration? Well, we know fluconazole is the only real choice there. Hormonal effects? A big, big problem for ketoconazole, but not for the others. And for drug interactions, ketoconazole is the worst offender, fluconazole is the safest, and itraconazole is somewhere in the middle. This table is your cheat sheet for clinical decision-making.
But the story doesn't end there, of course. As fungi evolve and new challenges keep coming up, our drug arsenal has to expand too. So let's briefly meet the next generation of specialists and also a powerful ally from a completely different family.
Now, these are not your general-purpose antifungals. Think of them as highly specialized weapons. Voriconazole, it has become the drug of choice for invasive aspergillosis, which is a very, very serious infection. And posaconazole is unique. It's the only azole that actually works against mucormycosis, another deadly fungal infection. So they're reserved for these very difficult-to-treat cases.
And now for something completely different. Terbinafine. It is not an azole, it's an allylamine. And here is the absolutely crucial point for your exams. Unlike the azoles, which are mostly fungistatic, meaning they just stop the fungi from growing, terbinafine is fungicidal. It actively kills the fungi. And it does this by inhibiting a different enzyme, squalene epoxide, which is a very early step in making the fungal cell wall.
All right, we have covered a lot of ground today. Now let's just boil it all down to the absolute essentials. These are the takeaways that you must carry with you from this session, into your clinical rotations and beyond.
So here is your bottom line. Number 1, think of ketoconazole mainly as a topical agent now, shampoos and creams. Its systemic side effects are just too risky. 2, for the brain and the CSF, your go-to is fluconazole. 3, itraconazole is your broad-spectrum workhorse for systemic infections that are outside the brain. And 4, for those really tough skin and nail infections, the fungicidal power of terbinafine is your best choice. If you just remember these 4 clinical pearls, you'll be very well prepared. And that brings us to the end. I just want to leave you with one final thought. We've seen this incredible evolution, from a flawed pioneer to these highly specific agents. But the fungi are not standing still. No, they are evolving resistance. So the real question for your generation of doctors and scientists is this: what's next? What new mechanisms, what new strategies will we need to stay one step ahead in this fight? Think about it. Thank you all for your attention.